Thank you to the meeting organizers and Dr. Montasi for the opportunity not only to visit your beautiful country, but to also present and then as well have the opportunity to prepare proceedings so we can continue to reach more individuals through the Meat Science publication as well with some of the content that we're sharing. I am happy to be able to present for my colleague and friend Marianne Binney while she's suffering from a back injury that landed her in the hospital. So we were able to connect this weekend and talk about our presentations a little bit and align them. And so what you're going to be getting today is a little bit of a 2-for-1. So try not to fall asleep, and I can guarantee you the only person that won't fall asleep is the translator, because I talk fast and I think I'll see the box steaming over there if it starts getting really quick. So feel free to raise your hand every now and then and tell me to slow down, because it's a good reminder for me as well. I would say that on behalf of Marianne and myself, I know we really appreciate the opportunity on behalf of our farmers and ranchers that we work for to present our scientific perspective on the role of red meat in health and well-being, and then also share what we collectively view as a time potentially for a paradigm shift. First, I think it's necessary to express some disclosures of my potential sources of conflict. I am a red meat eating registered dietitian. I didn't always work for farmers and ranchers, but I do now. And I love meat, I love red meat, and I think it's a very important food for health in my diet. I'm also raising 2 really smart and athletic and strong young girls who, when I think about all the choices that they could be making in their diets on a given day, I feel really good when I know they're getting their meat servings in, because I know it's nutrition that they need for their growth and their development. And considering, like I said, all the crazy choices that they could be making, I think they're making a good one when they're choosing their beef and their red meat. So enough about me, let's talk about what we plan to cover today. I really wanted to present the case for red meat in health and well-being. And in order to do that, I think we have to address the case against red meat in health and well-being and make sure we understand and appreciate that case. I want to touch on how the evolution of nutrition science and the history of nutrition science, how it's changed, and that's changed how we view the case for red meat and health and well-being and the case against red meat and health and well-being. We'll talk a little bit about enjoyment of foods and consumer preference and how that really does impact at the end of the day whether or not we're going to be successful in helping individuals move towards healthier diets. And then share some recent evidence on the role of red meat and increased red meats in diets that are healthful dietary patterns, and show you some of the evidence supporting positive outcomes with red meat in a healthful diet, primarily due to its high quality protein or its combination of essential nutrients like we heard in our first speaker today. So I want to start with, and as I present today, I want to give you the backdrop of what's happening in nutrition science and nutrition research so you can sort of appreciate why we say what we do about red meat in the role of health and well-being, and kind of give you some context and maybe provoke a good discussion through the question and answer session as well. But the 1940s and 50s really represented a paradigm shift that would forever change the way that we view the role of red meat in health. Up in the 1940s, meat was seen as a nourishing food. We've got to appreciate and recognize that vitamins were still being discovered in the 1930s. So much of what we thought about in nutrition at that time was ensuring that we got adequate nutrition and that we were preventing a nutrient deficiency. And so meat was seen as a valuable source of nutrients and high-quality protein. And that started to change a little bit between 1940 and 1950, when also in nutrition science, we began to ask other research questions. Questions like, could diet be related to this epidemic of heart attacks that we're seeing in middle-aged men? Is there something about diet related with that? So there began to be more research questions around that in an attempt to understand that better, there were 2 major observational epidemiological studies that were initiated to begin to look at those associations. The Framingham Heart Study, which was conducted in individuals in Framingham, Massachusetts, and then the famous 7-country study, which compared diet intakes from regions around the world and associations with heart attacks in those countries. Raise your hand if you've heard of Framingham Heart Study and the 7-country study, just so I can track about how much background we've got. Okay, so these studies were large observational or epidemiological studies. These are the kinds of studies where you have lots of people, cohorts of individuals, but you don't have an intervention. You are just making an observation about the occurrence of the disease that population is having and what kind of dietary exposures they may be experiencing. So you're looking to generate hypothesis or find associations. In the hierarchy of scientific evidence, that's really small down there at the bottom. But the point is that these kinds of observational studies provide important evidence in nutrition research, the cohort and the case control studies, but randomized controlled trials up here are still considered the gold standard pieces of evidence. But nonetheless, we need to start with observational studies so we can understand, is there an association between diet and heart disease? And they do determine associations, but they don't determine cause and effect. That's a key point that you'll see a theme emerging throughout my presentation today. Nonetheless, the Framingham Heart Study and the 7-country study begin for the first time, this was in the 1950s, to establish that diet, particularly the amount of fat and saturated fat that we consume, puts us at risk for cholesterol, high cholesterol, blood pressure, and heart attacks. So there is an association, not a cause and effect, but an association. But that data was important enough and significant enough that it, along with other observational studies after, drove global health guidance to reduce the amount of saturated fat in the diet. That was a big step there in that paradigm shift, because now we have evidence from these observational studies to inform public health guidance, and we get guidelines around the world to start reducing the amount of fat and saturated fat in our diet. In the US, those first guidelines came in the 1980s, and among the other things that we were going to be doing to improve our health, number 3 was we were going to start to avoid too much fat, saturated fat, and cholesterol. Now imagine that you're a public health nutrition person or a dietitian in the 1980s and you have to start teaching people how to avoid a nutrient. You've got to translate that into food-based guidance, because people don't eat nutrients, they eat foods. And so therein lies where we first start to focus on food sources of saturated fat, cholesterol, and total fat. And animal fats were the predominant source of fat in the diet at the time. Beef was a top contributor of saturated fat. And so you can start to see how these foods red meat starts to become a target as a means for reducing saturated fat and cholesterol. Now that inspired or motivated the industry, the red meat industry, through a collective effort from farm to fork to reduce the fat content of beef. You remember if we show those old Hereford cattle pictures, short and really fat, and now cattle look a little bigger and leaner today than they were. So we have an effort to reduce the amount of fat in the diet. On beef, and pork has a similar story to tell. So that today, the external trim fat on beef is 81% less than it was when that picture I showed you up when those first dietary guidelines were issued. And as a result, mainly of the external trim fat, about 2/3 of the beef cuts in the retail case of the US meet our government guidelines for lean. And pork is 20% leaner than it was even in the 1990s. So we've got an advancement in the availability of leaner red meat. We also, I have to acknowledge, if you've been watching any of the media in the last 6 months, increased skepticism over whether or not that diet, saturated fat, heart disease hypothesis was really all it was cracked up to be. There's been some major studies over the last 10 years that have called into question that link, the significance of that link, and a recent book by Nina Icomst that really makes a compelling case for the rocky ground that scientific evidence is built on. Now, I want to be crystal clear. There's definitely not scientific consensus on this. And while there's people questioning whether or not saturated fat really does put you at risk for heart disease, the American Heart Association and all leading health organizations worldwide that I'm aware of still are firmly rooted in recommending that you eat a low saturated fat diet. In fact, most recent guidance came to even lower your saturated fat from 10% of your calories down to 5 to 6% of your calories if you have any risk factors, and most people over 40 have some sort of risk factor. So there's a friend of mine in science who says, who quotes a German physicist who was known for saying that science only advances one funeral at a time. And that may certainly well be the case with the dietary saturated fat hypothesis, because while I know, I work for farmers and ranchers, they get really excited about hearing about this challenge to the saturated fat hypothesis, and sometimes I have to be the bearer of bad news and let them know that public guidance isn't going to be changing overnight. Now, while we have our link between saturated fat and red meat, and that's an image that's firmly held in people's minds, and it always comes up, it's always in the reasons why we have a case against red meat. This issue of the Western dietary pattern is the issue we really face today about overcoming the case for red meat. It's very difficult to make a case for red meat because of this Western dietary pattern. I heard it mentioned, I think, in both presentations to this point. What is this all about? So when those observational studies were being conducted, I told you about the Framingham and the 7 countries, and there were other studies after that you might have heard of, like the health professional follow-up or the nurses' health study or the EPIC cohort, all these observational data. They realized that if we're looking at associations with your diet, you can't just look at an individual nutrient or an individual food, because we're not having an intervention in these people's diets. We're just collectively looking at sort of trends in their diets. So they begin to think about studying patterns. Are there patterns in these people's these diets that we're observing that might inform us about whether or not there's a risk of an outcome? So 2 distinct patterns emerged out of the health professional follow-up study that then ended up over the last 10 years. This is the way observational data is looked at. You take these associations and you say, basically there's 2 kinds of dietary patterns that emerge. The Western dietary pattern, which is those individuals who have high intakes of red meat, processed meat, butter, potatoes, refined grains, and high-fat dairy. And then the distinct other pattern is what we call the prudent, or now the healthy pattern: vegetables, fruits, legumes, fish, seafood, whole grains. So there's kind of 2 different types of people and eating 2 different kinds of way. And their risk association with their health outcomes seems to be different. So that's a very important concept, because the Western dietary pattern is consistently associated with negative health outcomes like obesity and diabetes. In fact, it was this kind of observational evidence that was the primary case, the main part of the evidence used when the World Cancer Research Fund judged that red meat was a convincing cause of colorectal cancer. So these observational data don't have the ability to disentangle specifically individual foods, and so we have to look at the best we can do with separating them. So you might be wondering, is anybody wondering this? So is red meat guilt by association? If red meat is part of this Western dietary pattern, is it guilt by association? And I think one of the things I get to do or have to do in my job almost every week is address the study of the day. That's what I call them. It's the study that you hear about some negative outcome with red meat. And this table right here is from one of the ones that got the most of attention. In fact, this study was published in 2009. There was just a story about it yesterday, another article about this, citing the same evidence. Did anybody hear about this study, that higher intakes of red meat were associated with higher rates of mortality? So this is one of those observational studies with a cohort of 500,000 people, and we looked at broke these individuals down by quintiles of meat intake from low, less than an ounce, 18 grams of meat per day, up to 68 times 2, basically 125, 130 grams per day, so about 4.5 ounces. So you see I've got a stepwise increase in meat intake, and the higher those individuals in this study, those individuals who had the highest levels of meat intake had the highest risk of mortality. Okay, so if you look at this first table, this is table 1, the baseline characteristics of the subjects before any of the statistical models or anything are done. And it's very telling. I don't know if you can see this, but I'm going to just tell you what it says. Basically, the individuals who had the highest level of meat intake, they also had a higher body mass index. They were also more likely to be a current smoker or having only quit within the last year. They were less likely to be educated, college educated, more likely or less likely to be engaging in vigorous physical activity, more likely to consume more calories, less likely to consume more fruits, less likely to consume more vegetables. So that's the Western dietary pattern that I just showed you. It's not really surprising, but so in statistics and nutritional epidemiology, they can adjust for these things, and they do adjust for these things with statistical methodologies. But even the authors themselves acknowledge there's always that question about how much you can really control for that. There's another quote by a statistician who says, "Statistics are like bikinis. So what they reveal is suggestive, but what they conceal is vital." So that may be the case as well with these statistics and the observational data. In fact, just in the last month, there have been 2 papers, commentaries published that really call out the uncertainties of using observational data in isolation in order to make public health recommendations. One of these papers is from 2 past members of our U.S. dietary guidelines who sat at that table trying to make public health guidelines, looking at this evidence, and faced the challenges to feel certain with making a public health recommendation based on this kind of data. I shared the concerns about residual confounding or confounding in that previous slide. There's also the issue about diet assessment. In these observational studies, you have to go to these individuals and ask them, what are they eating? What did they eat last week? Maybe what did they eat the year before? And draw association. So people are not very good at recalling their intake. Our methods for assessing food intake are not very good. So dietary measurement error is a big challenge. And the other one that I want to address specifically is weak or modest associations. In observational data, you usually report your results as a relative risk or an odds ratio. A relative risk of a 1.0 means that there's no effect. You had a neutral effect. There was not an association. By contrast, for example, an association that we infer as a causal relationship like smoking and lung cancer, that association is a 10.0. So 1.0 is no effect. Smoking and lung cancer is 10.0. Most nutrition observations are 2.0 or less. And most epidemiologists would call that a weak or modest association. Just to give you an idea on the red meat and colorectal cancer association, if an association is identified, which is not in every case that's reported, and if that association is statistically significant, which you'd be surprised how many studies are published that talk about results that are not statistically significant in nutritional epidemiology, you will see a relative risk of about 1.2 to 1.5. So that gives you some context about the weak association. When associations are that close to 1, they raise uncertainty about whether or not that observation could have been done due to chance or confounding or selection bias or a lot of other things. So there's a lot of uncertainty in that data. So they conclude that the strongest recommendations in public health should be saved for when the observational data, those epidemiological studies, align with that higher level of evidence, the randomized controlled trials. Now, this is a key point that I'll make, because those healthy dietary patterns that I mentioned, those Western patterns, they have since gone on out of the observational studies to be tested in large-scale randomized controlled trials. And those two examples are the DASH study, the Dietary Approaches to Stop Hypertension study, the DASH diet. If you haven't heard about the DASH diet, write it down because you will hear about it. It's the gold standard diet that's raised up as sort of the example of the way we should be eating. And then there's the Predimed study that tested the Mediterranean diet in a randomized control setting. There's really very good, strong, solid, great scientific evidence, a great case for eating these types of diets for improving your health outcome. So these are diets that are regular consumption of fruits and vegetables, whole grains, low-fat dairy, fish, nuts, and because they have all those foods in them, they're also low in red and processed meats, sugar-sweetened beverages, and foods. So this diet is a very successful way of achieving good health. However, it should not be used to make the case against red meat, and that's the major flaw with translation of so many of these diets, so many of this evidence from DASH. These tell us nothing about a diet that is rich in red meat. And let me give you some specific examples because it's a big flaw in nutrition and the interpretation of nutrition evidence. The DASH study, which is also used as a proof that you should be eating a diet low in red meat, was conducted over 20 years ago. If you go back to the original DASH studies, there was no intentional reduction of red meat in that diet. But when the diet was translated to a low saturated fat diet, well, how did the dietitians and how did the menu planners get that low saturated fat diet? They cut back on meat because I told you earlier that we had a lot of external fat. So it was a practical application. The Predimed study, the authors themselves in the randomized controlled trials published in the peer review state that the effect of the Mediterranean diet was seen from the supplemental olive oil and the nuts, not differences in red meat intake. Another study that's often highlighted, the OmniHeart study, which is used to make the case for more plant protein, actually the red meat servings in the control and the OmniHeart were exactly the same number of red meat servings. So these studies make the case for a healthful dietary pattern, but they don't make a case against red meat. And what we need to do in order to see if we have a case for red meat and health and well-being is understand, do we have any evidence on healthy dietary patterns that also include red meat? You guys tracking me, following along? Yes, making sense? So we've got to start with heart health because that's the area that we've got to overcome the most. That's the biggest challenge. Physicians, nutrition scientists, ordinary people, parents, everybody thinks beef and pork and red meat raise cholesterol levels. Actually, ironically, this is the area of science where we have the best quality evidence. We have at least 12 randomized controlled trials conducted since the first dietary guidelines that consistently demonstrate the same thing. If you eat a diet that's rich in fruits and vegetables and whole grains, and you substitute everyday lean red meat in place of white meat or plant foods, you're going to get the same cholesterol lowering effects. Same effects on blood pressure, same emerging risk factor effects, very similar responses in response to eating red meat daily. And actually, we say lean red meat, but we conducted a meta-analysis on the 8 randomized controlled trials that looked just at beef, and there was a mix of lean beef and non-lean beef in those studies, and we still showed an effect to lower cholesterol and overall from a diet from diets that contain 3 to 6 ounces of beef every day. The most recent piece of evidence is probably one of the ones that we're the most proud of. Farmers and Ranchers supported this study, the Beef in an Optimal Lean Diet study conducted at Penn State with Penny Chris Etherton and co-workers, just published within the last year and a half. Basically what this study did, a randomized controlled trial that took the DASH diet, the gold standard DASH diet, and went head-to-head with it with what I call a beefy DASH diet. Basically, it took out the white meat and the plant protein and the nuts, decreased those a little bit in the DASH diet to make room for 4 to 5.5 ounces of beef every day. And what we showed is that the cholesterol lowering effect on the LDL cholesterol effect was the exact same as seen as in the DASH diet. The Bold Plus This treatment was a higher protein version, substituting one more serving of beef for a serving of carbohydrate, and still we see that we lowered cholesterol 10%. So the authors conclude that the study provides convincing evidence that lean beef can be included in a heart-healthy diet that meets the recommendations. Now, if you read back through these randomized controlled trial papers, these RCTs, a lot of times the authors in the discussion will say, well, you know, really when you look at the fat profile of meat, it's not surprising that it wasn't hypercholesterolemic. And I think this is something that's very underappreciated, and a little bit of my soapbox to meat scientists that I would say, because I think we spend a lot of time talking about modifying the fatty acid profile to improve the fatty acid profile. And I appreciate what the speaker said earlier today. She thought it was less about the overall fat composition. What a lot of people don't realize is just beef in general, grass or grain finished, has predominantly monounsaturated fats. About half of its fats are monounsaturated fat, the same fat found in olive oil. And of its saturated fat composition, about a third of it is stearic acid, and stearic acid doesn't raise cholesterol levels. Pork has a similar profile. So what I hope that we can do is get more awareness that overall, beef is not just saturated fat. It's half of it's monounsaturated fat, and of the saturated fat that it does contain, a third of it doesn't raise cholesterol levels. So really, when you look at the fat profile, you wouldn't expect it to be all that hypercholesterolemic in the first place. So the first point that I'm making today then is that you can have a prudent diet or healthy diet with lean red meat and get the same effects, same clinical effects on your cholesterol levels without unnecessarily restricting lean red meat. That's the first point. Why is that important? Because sticking to the DASH diet is a challenge. Most people, it's a pretty big departure to try to eat a healthier diet and change up the way that you're eating. In fact, there was a systematic literature review published last year that showed it's tough to try to change your diet this much. And what they conclude is that we're going to need help. People need help like nutrition counseling and other strategies in order to achieve this diet. Well, most people don't have access to nutritional counseling and other means for helping them stick to a diet. How many of you have tried to eat a little bit healthier, change up your eating, and find out when it's time to get to the dinner table or prep something, you don't know what to make on this new plan that you're following? It's a real challenge. So that's the incremental effect that including red meat can have, is perhaps it's helping with adherence to a healthful diet. This is data just from the US, just for beef. It's survey intake data from our National Health and Nutrition Examination Survey. When we polled individuals and asked them to report their diets to us on this day, 44% of adults said that they ate beef that day. 44% of US adults said that they had had beef on the day of this survey. If we added pork and other red meat to this number would be higher. So it's a common food. It's a frequent food. It's a core food in our diet. If we don't go home making our spaghetti dish or our tacos tonight, we might not have an idea of what to prepare for dinner. Now, I want to be clear though, just because it's a frequently consumed food doesn't mean that it's an over-consumed food. Because so many times I definitely hear my nutrition colleagues say, well, we need to eat less meat. We should be eating less meat. People eat too much meat. We should eat less meat. Based on how much? There's not an appreciation for actually how much meat we are consuming. In fact, beef consumption in the US is only 1.7 ounces per day. Beef consumption in the US is only 1.7 ounces per day. Now, if I did my numbers right, in Uruguay, is it about 5.5 ounces per day for red meat? Total meat? Yeah. Red meat, 5.5 ounces today, and I don't know if that's disappearance data or actual consumption data, but it's about 1.7 ounces of beef in the US, 2.5 ounces of red meat in the US per day. And my colleague, this is Marianne's slide, we've looked at intakes around the globe from our International Meat Secretariat colleagues, and most of us from our countries find that we are consuming meat intake within our country's dietary guidelines, within the recommended amounts. So it can be a frequently consumed food, but it's not necessarily an over-consumed food. That's because people have this image that we're only eating steaks and hamburgers. And actually, the most common way that beef is consumed at home in the U.S. is ingredients, spaghettis, skillet meals, and dishes. So the image is not what we're actually doing. So you can have frequent servings of beef, but maybe not having a big steak or a big burger. So if we're only eating 1.7 ounces of beef and 2.5 ounces of overall red meat, where are calories coming from? This is from our 2010 Dietary Guidelines report, and what it shows is that, yes, it makes sense why we have an higher levels of obesity. We're eating 600 calories more in 2008 than we were in the 1970s. But look, I'm going to walk you through here. This is, the purple is meats. The meats have only changed by 50 calories in those years. 50 calories in, what, 40 years. Whereas the flour and cereal products and the added fats and oils have increased about 400 calories between the two. So there's been a shift in intake. Meat, eggs, and nuts, we've kind of held off. We kept the same. And 200 more calories, from 400 to 600 calories of added fats, 200 more calories from flour and cereal products. So you do start to wonder about the diet quality and the nutrients that we're getting. So that takes me to my second point. As you saw in our first presenter, meat contains a lot of nutrients that complement other foods in the food supply. Beef and pork, for about 120 to 150 calories, you're going to get 6 to 10 essential nutrients. Nutrients that are known throughout the world and even in the U.S. to be short in the diets. Things like iron and zinc and choline, selenium, and obviously a good source of protein. So we don't eat nutrients, we eat foods. We don't eat just for nutrition, we eat for taste. So the second point that I want to make is that the incremental effect that red meat might have is actually helping people stick to diets that we really want them to eat. So getting a little bit more of an advantage to helping accomplish the DASH type diet or the Mediterranean diet. And I think we're at a state, at least in the US, where even our top public health decision makers are soul searching a little bit and saying, you know what, we've seen obesity rates rise. We're going to be open to exploring other options. Maybe we have to recognize that only 3 in 100 Americans, only 3 out of 100 actually do our guidelines. They eat their fruits and vegetables, they get their physical activity, they eat a low-fat diet. Maybe we need to, as we would say, skin this rabbit a different way, right? So they're beginning to explore protein intakes. How many of you are hearing more about higher protein diets and the benefits that more protein in the diet may be? See, for so long, nutrition guidance and protein recommendations were based in the RDA. The minimum daily average of dietary intake that meets the nutrient requirements, it's 0.8 grams per kilogram per body weight per day. It hasn't changed. It's not changing. It's staying the same. This is the amount to meet the minimal needs. But protein was largely ignored for a long time because, you know what? Really across the globe, we eat a pretty consistent amount of protein. 10 to 15% of the diets have come from protein. Through all these diet crazes, all these dietary advice, all these changes, our carbs and our fat have changed, but our protein amount has pretty much stayed the same. It's stayed relatively constant. So in that way, protein was kind of an ignored nutrient in nutrition. People didn't really pay a lot of attention to it. They were so focused on carbs and fat in scientific research. But recently, there's been a renewed interest in understanding higher intakes of protein. And the Institute of Medicine gives us the RDA, this number, but they also give a range of macronutrients that allow for more flexibility in protein. See, we eat protein, carbs, and fat in some ratio of each other. And what the acceptable macronutrient distribution range does is it tells us from the Institute of Medicine that you can build a healthful diet that's associated with reduced risk for chronic disease by eating 10 to 35% of your calories from protein, 45 to 65% of your calories from carbs, 20 to 35% of your calories from fat. You can mix it up any way you want as long as you stay in those ranges and you choose nutrient-rich foods. So that gives us a lot of flexibility then to explore intakes above the RDA. Yes, it's true, we don't have a protein deficiency. No one's falling short of getting their protein. But there's this opportunity in this window that increasing protein, still within the Institute of Medicine recommendations, may be associated with health outcomes. The one that probably gets the most attention is, do higher protein diets actually help with weight management? And this is a nice quick overview because it's a meta-analysis of 24 weight loss trials that was conducted in over 1,000 adults, a 12-week weight loss. Basically, you'll see between the red and the black bars, everybody loses weight when they go on a diet, if they follow it, right? But those individuals that were eating in this range of protein, doubling basically their protein intake at the expense of a carbohydrate intake, still have carbs. They're still eating carbohydrates, but they're just substituting out, say, a serving of protein for a serving of carbohydrate or so. They lost 2 more pounds. They lost more fat mass and preserved more muscle mass. See, that's what you want to do when you're losing weight. You want to be able to lose fat but maintain your muscle, so you have more metabolically active tissue. When it's time for you to start eating more calories, you have something to burn it, and muscle's going to burn more of those calories than fat will. So that's an advantage there with weight loss. Now, just beyond the numbers on the scale, there's some real new fascinating research that there may be not only the actual numbers, but physiological and emotional rewards from higher protein diets. This study was conducted out of University of Missouri by Dr. Heather Leidy and her team, looking at breakfast skipping overweight adolescent girls. So I don't know if any of you have a high schooler. I have one approaching 7th grade. They tend to want to skip breakfast because they'd rather sleep in. And so they took these overweight adolescent girls that were breakfast skippers, and they introduced breakfast back into their diet. They said one group's going to get cereal, the typical breakfast. The other group's going to get a high-protein breakfast. We've done this with beef and with eggs and pork, and then another study with eggs and beef for breakfast. And we'll see what happens. Well, these individuals, the girls that were eating the higher protein breakfast, what's very interesting is even though they reported similar levels of satisfaction, they ate 200 less calories of unhealthy snacks in the evening. So they were given a little cooler pack with all kinds of snacks in it, and they got to eat whatever they want out of there. And the girls that had had higher protein for breakfast ate 200 less calories out of that cooler pack than those individuals that had the cereal breakfast. And when she looked a little bit closer at what was going on there, she looked at brain imaging scans, functional MRIs, and I won't even pretend to know how to read these, but I'll tell you that basically what she showed is that the centers of the brain that are associated with food cravings and food reward were blunted in response to the higher protein diet. So those girls that were having more protein in their diet had less activation of the centers of the brain that control food reward, that make you want to eat food for pleasure or for reward. So there may be a physical and an emotional satisfaction component, because we also show that hormones are changed, the appetite hormones are changed favorably when you have more protein in your diet. That's for weight loss. There's also an increasing amount of attention and good evidence, and I would say pretty much scientific consensus that older people may need more protein than the RDA. The RDA is 0.8 grams per kilogram. This paper, consensus paper published, says it's 1.0 to 1.2 grams per kilogram, that body weight that older people need. Basically, as you get older, you're a little bit more resistant to your body using the protein that you consume, and you may be faced with chronic disease that's causing your protein needs to be higher. So increased protein can be really important, especially for aging. We know that muscle maintenance is so important for your functional health, and your functional health is so important for maintaining your independence. Because those, I think there's a statistic that says that 50% of women over the age of 60, which is young, 60, who fall and break a hip, never walk again. So we all know those folks that are in their 50s and 60s who get down with a knee injury or a back injury and don't fully recover, and we lose muscle over time, and we lose our functional independence. So increasing protein can help with that. Related to that topic, there was some research out of Australia that took women living in a retirement village that were aged 60 to 90, and they just supplemented their shopping cart, their food list, with the equivalent of 5.5 ounces of lean red meat, and the other group were just told to have more pasta or rice. And then they worked them out 2 days a week with resistance exercise. And what they found is the addition of this lean red meat, muscle strength increased in these women that are 60 to 90. Insulin-like growth factor increased, pro-inflammatory markers improved, and once again, they had no differences in their blood lipids and their blood pressure, so their cardiovascular doctor should be happy as well. And I think this is important because a lot of people that are over 60, a lot of women, I know my mom is one of these examples, she doesn't think she should resistance exercise because she doesn't think she can build muscle anymore or have strength. And you still can increase muscle and strength past 60. Meat has a calorie advantage for those people losing weight or older people because anytime you need less calories, you want to get more nutrition for that. So beef and pork both, for about 120 to 150 calories, can get you 25 grams of protein, yet a lot of people, so many women turn to things like peanut butter thinking it's a better, for their protein source, and you'd have to eat 564 calories of peanut butter to get 25 grams of protein. So meat is a really concentrated source, and if any of you have tried to eat a higher protein diet or try to get more protein at breakfast, you know that meat is a really easier way to get it because it's a concentrated source of protein. So that's my third point, is that its high quality protein satisfies and strengthens. Now, just wrapping up with just a few additional comments, and my fourth point, thanks for hanging in there. I don't see very many people sleeping, so I know that's appreciated. One of the things that has always struck me about having worked for farmers and ranchers is I have people come up to me who say, oh, I need beef. I love beef. I just feel better with beef. Or I was a vegetarian and I started eating red meat and now I feel better. And when we talk to consumers, they tell us, when we say, if you do eat beef for health, why do you eat it for health? A lot of times what they tell us is, I just feel better. I just feel better when I eat it. I don't know how to describe it, but I just feel better. We've been wanting to know, what does that mean? What does that mean when you feel better? So we've been interviewing younger generation folks, those what we call millennials in their 20s and 30s, and asking them, and they're telling us things like, beef gives me the strength and energy to do more. It fuels my journey for good health. It gives me physical energy that I need gives me a mental boost. And so these are areas that we have an interest in further exploring. We know that meat, I think this first speaker mentioned it too, the iron and zinc content of meat can be an important first food for babies. This is research from a randomized controlled trial. It's a small study, but there's others like it with Kenyan children where they supplemented meat in these children's diets and they improved their growth and their cognition. Interestingly, the meat supplemented children had more initiative in the schoolyard. They were more likely to engage in physical activity. They exhibited more initiative and more leadership behavior from meat supplementation. So this impact on cognition and physical and emotional satisfaction is an area of interest. On the other end of the spectrum, those were kids. There's been research out of Australia that has shown that same DASH type diet with added lean red meat improves mood as well. So we had the DASH China diet and then the beefy DASH that I've sort of been talking about. And in these postmenopausal women, their mood was better, particularly with relation to anger, and they were less likely to report depression. So we've got potential for meat beyond its essential nutrients preventing a deficiency, like we talked about in the 1940s, to meat's role in a future of potentially supporting vitality and stamina, especially as we think about how it might help people stick to healthier diets. I have a hypothesis that vegetables taste a lot better when they're paired with beef. So that's been an interest of our beef checkoff research. We want to understand this area of vitality and stamina and physical and emotional satisfaction more. That's the program I lead, is trying to identify research studies around the globe that may be able to help us address that. Just a quick comment on recognizing for sure that industry-funded research is always challenged and has some skepticism around it. One of the things about checkoff-funded research, the kind of research that Marianne Benny's group supports and our group supports, is the researchers have full control and design over the study. We ask them, and in our contract, they have the obligation and freedom to publish. They own the data, we don't own the data. These are some of the contract commitments that we have through our grant support that are in line with what the nutrition community has called in for ethics in nutrition science. And so I think that the kind of research that we do is very high quality, very credible research that has the integrity expectations that the scientific community has asked us to have. So just in closing, Mary Ann was going to tell you that it is time for a paradigm shift, and hopefully my support points build that case as well. We think the scientific evidence to support lean meats inclusion in an overall dietary pattern for heart health is strong, that we really believe that it's through preference for red meat that can help anchor a healthful diet, that higher protein diets in general with the added inclusion of lean red meat can support weight management and healthy aging, and that red meat supports a favorable physical and emotional outcomes for a variety of life stages. We always say in nutrition, it's not evolutionary, it's revolutionary. So we've talked about one paradigm shift. I'm optimistic that we're discovering a new potential paradigm shift. There's definitely rough roads ahead for red meat. We don't have a public health environment that's inviting red meat in, but I think we have a consumer base that is experiencing benefits from eating higher protein diets that are really starting to push the health community to think more and think differently about what we're recommending in diet, and I'm optimistic about that. So that concludes my presentation.